All right, everyone. Thank you so much for joining us today. Today's webinar will be given by Dr. Alex Vaccaro, our spine surgeon and president at Rothman Orthopaedics. Dr. Vaccaro will give his presentation. Please feel free to put in your questions at the Q&A box at the bottom of the screen, and we'll take a few minutes to answer as many as he can at the end. So thanks so much for joining, and you can take it from here, Dr. Vaccaro.
Thanks, Natalie. It's an honor to be able to speak to you today. I will be giving a lecture every quarter on common spinal problems. We respond at the Rothman to questions that referring physicians have and patients have about what they want to learn more of. And unfortunately, everyone has neck pain and everyone has back pain. And if you look at a life prevalence of a back disorder, 80% of us at one time or another will have significant back pain. 70 to 80% of us will have significant neck pain, and everyone gets nervous about it. So I'm going to take you through a little tour of how we evaluate at Rothman someone with a neck problem. So the first thing you have to understand is what is natural aging and what is pathologic aging. As we get older, and I always say life is a kyphosing experience. Kyphosis, it means you bend forward. As we get older, we get shorter, our discs degenerate, they get smaller, and we tend to have a forward posture. That's just normal aging. But some of us have really bad neck pain, some of us develop arm pain, some of us develop weakness, and then others really develop bowel and bladder dysfunction and difficulties with fine finger dexterity and difficulties with gait, balance. And that's just to, if you look at these pictures, what happens over time as a disc collapses, which is normal. Sometimes a disc can herniate back into the spinal canal. And I don't know if my cursor shows up, but you can see how this disc is now coming into the spinal canal. And then this disc is really coming in. And as the disc leaves its space, the body reacts to it because it's not normal. There's inflammation, there's bleeding, and then bone forms around it to stabilize. And that bone cause bony spurs that go into the spinal cord. And then you see over time that can cause a significant amount of problems. In the top right corner, you see that little white dot on the spinal cord, and that's called myelomalacia. And myelomalacia is basically gliosis or scarring of the spinal cord. And when that happens, that's a problem because 68 to 72% of the time, that is progressive and patients can get paralyzed. So when you see a relative that's walking funny with sort of a wide base gait, forward bent, and shuffling, they may have spinal cord compression. So if you look at the anatomy, and I love these anatomy slides, this is just the spinal cord in a cross section. And again, hopefully the center arrow, hopefully my cursor shows up. If it doesn't, I apologize. But you can see the spinal cord being compressed at this level of a disc herniation. And on each side, those are the foramen, and the foramen is the exit passageway where the nerve comes out. And you can see the joints on the side. And it's very simple. You have a vertebral body, disc, vertebral body, and on the sides of the disc, you have what they call the uncovertebral joints, which connects one vertebral body to the next. And sometimes they can get large, and they pinch the nerve when it comes out on the side. So you can see that right there on the side. And then if you look at a side view, an oblique view, you could see where the nerve comes out. These are called the foramen, which is great. So on the top, you have a pedicle, which is just a bony connection between the elements in the front of the spine and the elements in the back. You have the pedicle from the level below. And then in the front, you have the vertebral body. In the back, you have what they call the facet joint or articular pillar. And you can see as this gets more degenerative, it starts to crowd this area. And that can be a problem. But what's really complicated is that we have two large arteries in the neck that can give us problems if they get occluded. It could lead to stroke. It could lead to balance problems. It could lead to visual problems. And those are the vertebral arteries. And that's this red thing. And it goes right up along the spine. And as I said before, when the spine begins to degenerate, all the joints get bigger. And this uncovertebral joint here can push on that artery and cause problems. The scariest thing is when we as surgeons have to take the pressure off the spinal cord, we have to be very careful that we don't violate that vessel because it can be catastrophic. So these are the things that we think about as surgeons when we operate. So what does it look like on an MRI and plain x-rays? This is just a young woman with arm pain. So if you look at the plain x-rays, this is a side view lateral, it looks normal. You look at the MRI side view, you see like a little bit of a disc herniation at C5-6. And then you go to the far right and you look at the transaxial view and you see this little small disc herniation pressing on the spinal cord. Well, The nerve doesn't like that. The spinal cord is not being severely compressed, but the nerve is being pinched, so the person has arm pain. So now you have a visual understanding of why people have arm pain. This is a 57-year-old woman, a little bit older now. And again, plain x-rays show nothing funny. But if you look at the second plain x-ray, you don't see that nice normal curve, which is called lordosis, because we're getting older and the discs are collapsing and then the vertebral bodies tend to move more. And if you look at the first MRI, the sagittal view, you see this large disc herniation that really came out of place, went behind the body itself. And if you go to the far right transaxial view, that's a pretty big disc herniation. So this person, again, spinal cord's not crushed, but the nerve is, so they have arm pain. Now, if you get, as you get older, besides having disc herniation, the joints get bigger everywhere. And if you look at your fingers when you get older, if you look at your knees, you'll say, wow, my knees are getting bigger. You have osteoarthritis. Well, when the joints in the neck get bigger, they crowd the neural elements. So if you look at this picture, the plain x-rays, you start seeing bony osteophytes in the front. You start seeing the disc begins to collapse. And if you go to the MRI, you could start seeing that every level, disc, 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 pressing on the spinal cord. And now the spinal cord itself is starting to turn white. And that's the myelomalacia I told you about, or the gliosis, which is scarring. You could have only 6% of the tracts being viable in the neck and still function. But you're going to have pathologic reflexes. You're going to be hyperreflexic. All the long track signs will be there. You'll start noticing that your handwriting is not normal. You'll start noticing your balance is a little off. So this is a dangerous thing. So you have to be very careful. And this is just another example of a younger person who has multiple level disc herniations. And you can look in the far right, and the spinal cord at each level is crushed. And this person clearly has a gait problem, and you don't have to have pain. That's the weird thing. When you saw the disc herniations before, the person had arm pain. And we've done experiments. To get pain, you need inflammation. In the absence of inflammation, you'll just have weakness or dysfunction. And that's why we tell patients say, well, my pain went away. I'm okay. And I say, no, you're not okay. You have severe pressure in your spinal cord and you could be paralyzed because you're acting as if you're becoming paralyzed. So even in the absence of pain, you could have significant pressure. So how do we treat this? Well, most of us will initially present with neck discomfort. What do you do about that? You stretch. 70% of the time, it's going to get better. So stretching, intermittent anti-inflammatories, physical therapy. 70% of the world that comes to us, that's all you need. You don't need to do injections. You don't need anything crazy. Most people will get better. The 30% of people that don't get better, then you may get into an organized physical therapy program. And then occasionally a small percentage of patients will have injections. That's it. Only 5% of patients that come to us will progress to the point where they may need to have an invasive, minimally invasive procedure. So what do we do surgery for? Well, we never operate in neck pain in the setting of degenerative disease because we don't really know where pain comes from. So if someone has neck pain and back pain, 99% of the time, you're not getting surgery because we just are not smart enough to understand where the pain is coming from. But we do operate for people that fail to get better with arm pain, which is radiculopathy, or people that have spinal cord dysfunction, which is myelopathy. And then we look at all the different attributes of their imaging studies. Well, is it an arthritic spine? Is it a non-arthritic spine with just a disc herniation? Is there instability? Is it pressure in the front? Is it pressure in the back? And we sort of put that all together to come up with an understanding. And then we superimpose that on the lifestyle and the genetics of a patient. If someone's a big smoker, they tend not to do well with surgery. They tend not to heal very well. If they have a metabolic problem like ossification of the posterior longitudinal ligament or diffuse idiopathic skeletal hyperostosis, that's a complicated surgical procedure. Do they have swallowing problems to begin with? Because if I do a neck operation, I'm going to make that swallowing problems worse. And if they're a singer and stuff like that, you've seen people that have vocal cord paresis, which happens very infrequently, but it can happen. So we put all that together and then we sort of come up with a plan and we say, what are our goals? Our goals is individualized to the patient. And I make a Venn diagram. What are their symptoms? What is their examination? And what are the imaging studies? And you put it together and you understand your goals. My goal is to take pressure off the neurologic structure. Do I want to preserve motion and do a cervical arthroplasty? Do I want to provide stability? So I do a fusion. I have to make sure that the alignment is appropriate so they don't develop junctional disease in the future. So I sort of put it together to make sure it's okay. Now, this is one of the best studies. This is a study that we wrote, and our premier journal in orthopedics is called JBJS. So that's if it's like JAMA or New England Journal of Medicine for the medical physician. So this is a journal, and we looked at the natural history of how do people do if they have surgery in the setting of degenerative disease. And what I want to show in this slide is sort of complicated, but we broke it up into three different categories: mild disease, moderate disease, and severe disease. And people with mild disease with spinal cord dysfunction, and I'm going beyond arm pain and neck pain, I'm talking about spinal cord dysfunction, they benefit from surgery. So a lot of people come to my office, they have bruising of their spinal cord, they have mild symptoms, and we've now seen that they will progress 68 to 72% of the time. And if we intervene earlier, their outcome is so much better that if we wait until they become moderate or severe disease. So that's an interesting scenario. So here's an example, and I mean this is a horrible example. This is a patient, 71-year-old, severe degenerative disease, large disc herniation at C3-4, but the disc herniation goes behind the body of 4 and is a 4-5 disc. So what do you do now? You can't just go into the interspace at one level, go into the interspace at another level, because you have pathology behind the vertebral body. So you literally have to remove the vertebral body. So that's we do this. So we had to go in. If you look at the far left picture, we had to take off all the bone that allowed us to take the disc herniation off the spinal cord. And then you have this big opening, and basically the head is disconnected from the spine, so you have to rebuild it. So you put a graft in, you put a plate in, and to give it more stability, you can go in the back of the spine also. So an operation like that can take 30, 40 minutes in the front, 30 minutes in the back. So it's like a 1 to 2 hour procedure. And the thing you tell patients with spinal cord dysfunction is that your goal is to stop them from getting worse, because sometimes the damage is done. So you don't want to overpromise. You say, listen, my job is to stop this downward decline to make you stabilized. And if we're fortunate, and if you've got the right protoplasm, good nutrition, eating well, maybe we can make the spinal cord somewhat better, but it's very difficult to do. So that's why you want to intervene earlier. And there's some people that need to have a multi-level procedure, and we have technologies now where we don't have to fuse. Take a look at this picture. This is called a laminoplasty. This is basically drilling on both sides of the lamina in the back, and you make a hinge, and you lift up the lamina to give more space to the spinal cord, and then you lock it in. So there's no fusion. This person has full range of motion with no fusion. So we have technologies now to do that. And what's hot now in America is doing procedures minimally invasively where you continue to preserve motion. And what's the logic of doing that? Well, we know that if we make something stiff, either because you have a bad disc and it's collapsed, or if we fuse it, it transfers stresses above and below, and it can wear down. So we have technology for both the lumbar spine and the neck called cervical disc arthroplasty, where we do the same procedure, take all the pressure off the spinal cord, but we put a mechanical device in to allow motion. And here's a perfect example. That is not a fusion. That's a mechanical device. And we say, well, how much motion is there to disc level? 8 degrees of flexion extension. So I always tell patients, and again, I'm a little bit more aggressive in what I tell patients. They will lose. If I do a fusion, you may lose 12% of motion. But if I put this little device in, you may get 8 degrees of motion, which is good. And here's a perfect example. Plain x-rays show not much degenerative disease. And you got to be careful, because if you have degenerative disease in the back of the neck and you put a disc replacement in the front, they may have neck pain, or it may not move because they can't move because the joints in the back are ankylosed. So this is a person who just has disc herniations at 2 levels. The other levels look fine. The CT scan doesn't show significant arthritis in the back. And CAT scan only shows spurring at the levels of interest. And you could put these devices in. These devices allow motion. See the flexion? So it's not a fusion. So we can do that now. And there's certain requirements that you have to have. It's not for everybody. You can't have severe arthritis in the back of the spine because it's senseless to allow motion if it can't move because it's ankylosed in the back. It can't be kyphotic because that wouldn't work out very well. It can't be unstable because that wouldn't work out well. You can't have severe osteoporosis or metabolic bone disease because it's a device that has to maintain motion and it can't subside in the setting of weak bone. So we say, listen, if you have the two joints, and look at this trace. These are the two joints in the back of the spine and then the disc in the front. If the two joints in the back are not moving, and you can take a look at the CT scan, those joints aren't moving, there's no sense to put an arthroplasty device in. Or if you have an abnormal kyphotic where the neck is bending in the wrong direction, it doesn't make any sense to put an arthroplasty device in because it's not going to function appropriately because your alignment's off. So in that situation, we do a fusion. So these are the things to think about. The other thing to think about is it's a mechanical device. So it can fail. It can ankylose. Believe it or not, 30% of these devices at 5 years actually become a fusion device because bone sort of grows in. And that's why it's important when I write these surgical pearls to make sure there's no bleeding, because when you bleed, you have bone morphogenic proteins and you have different cells that come into the area, and it can cause bony spurring and fusion and stuff like that. So there's things that we do. Now, if you look at all the articles, and I always tell people, we only really focus on articles that are written by surgeons without a conflict. Because if I invent a device and I publish on the device, more likely than not, the outcomes will be favorable. So you have to wait until the first IDE studies go through on these new devices, and they always say they're great because a lot of times the inventors are on these studies. So here's an example. These papers are written by people that may or may not have a financial interest on it. This is a meta-analysis, and it shows that cervical disc arthroplasty does extremely well, and it minimizes arthritis above and below. This paper, again, another meta-analysis, compared it to a fusion, and they said patients with an arthroplasty had better outcomes than a fusion. So keep that in mind. That's what the studies have shown, meta-analysis. But remember, this is a newer technology. But if you look at journals such as JAMA and New England Journal that really don't allow conflicting authors to publish because they sort of discount it, there's really no difference between someone who has a single level fusion and someone who has an arthroplasty. And that's what I tell my patients. I said, listen, if you're young and active and you think you want to preserve that motion, do an arthroplasty, but it may not matter because here's an article from JAMA that says there's really no difference between the outcomes. And if you look at, is there really a concept of junctional disease where if you make a stiff level at one level, it wears out the level above and below? Well, again, this is a meta-analysis that says it does happen. But the previous article I showed you from JAMA said it's really not a problem if you look at a non-conflicted group of patients. And that's why I have to compliment the Scandinavian countries. They're really good because of their national healthcare system to sort of have registries and data banks where everyone has to participate. They pay for your healthcare, your data becomes public data, and they look at it, which is great. So my last slide that I want to talk about is the conflict of interest. There's so many different things you can do to treat neck pain, arm pain, myelopathy. But the vast majority needs no invasive procedure. Rest, anti-inflammatories, non-impact physical therapy. And then when you move on from that, if you do need surgery, a simple single level fusion or a laminoplasty or an arthroplasty is good. And don't get sucked into what's new because what's new may not be the best. I always say, don't be the first to the party. Don't be the last to the party, but see how non-conflictive literature looks at a new technology. So in summary, we do a lot of arthroplasty at Thomas Jefferson University and the Rothman Institute, and we do it in the younger patients that want to remain active. But the bottom line is patients usually get better without anything. They can be managed in the vast majority of the time non-operatively. We only intervene when the non-operative modalities are not effective and when someone has myelopathy. Even mild myelopathy, we're pretty aggressive in that setting with mild myelopathy because we want people to get better. And we've seen that if you don't operate early in that disease, it can progress. The patients have significant dysfunction. I see people when I go out with my wife yells at me because I go, that person has myelopathy. Look at that person over there, they're shuffling, they have myelopathy. And she's like, okay, tonight you're not a surgeon. Tonight you're my husband. But keep that in mind, we're very aggressive. So I wanted to go through that in 20 minutes to sort of give you an overview to now open it up for questions.
Thanks, Dr. Vaccaro.
Okay.
So there
So
are some questions that came in, and I can read them
yeah, so,
to
so
you if that
Natalie,
works.
Natalie, you read the questions and
Okay, and you answer them. All right, perfect. So I'll start with this one. What is the next step if a rhizotomy for the neck does not last long, maybe only 3 months?
Okay, so that's a great question. That's a question that I'm tortured by because I'm assuming the person only has neck pain. So this is where we have to be sober in how we recommend treatment. So if a rhizotomy doesn't work, you have to stick with it. You can't just say, okay, non-operative treatment didn't work. Let's do a neck fusion for neck pain. It's not going to work. So you have to sort of work with the cocktail of treatments, anti-inflammatories, injections, acupuncture, all the non-traditional. I'm a big fan of acupuncture, but don't get sucked into we have to do surgery now because rhizotomies don't work. Now, there's a new science out there called spinal cord modulation. That new science has been used not only for neuropathic pain, but now for neck pain. Again, it's new. It's when people have debilitating neck pain, they put a wire in the canal with an implantable battery. It has the newer literature says it may be effective. I would probably avoid that also because if it's not effective, they put a trial in for 6 weeks and they take it out. But again, if rhizotomies aren't effective, I really feel bad for those patients because there's no magic wand to make neck pain better. And I apologize for that.
Thank you. How long does a cervical ablation work?
How long does it work? Well, um, the literature says a cervical ablation, which is radiofrequency ablation, has a 60 to 70% success rate. And I've seen patients that have had permanent improvement, and never had recurrence of their pain. And then I've had patients fail. But usually if it's productive, it can last 6 months to a year. I've seen it the whole spectrum.
Okay. Is it okay to do lying down flat, gentle neck flexion exercises to strengthen the neck muscles?
Yes, I love it. I mean, you just don't want to do impact loading. Like lying down is perfect. You don't want to do anything crazy. Like people say, what kind of neck exercises? I'm like, well, we can give you exercises for your upper extremities, but neck is just range of motion. I mean, don't force yourself to the extreme, but just try to condition the sternocleidomastoid, the strap muscles, the paraspinal muscles, the trapezius. You want to work on all the muscles of the neck to feel better.
Thank you. Is spinal manipulation or chiropractic treatment ever appropriate?
I'm a big fan. I'm a big fan of it. A lot of my patients love it. Now there's low velocity, high velocity, and it gets complicated. Uh, but I defer to my chiropractic partners on that. But patients love it. Now, you don't want to do chiropractic manipulation if you have instability or if you have significant osteoporosis or if you have metastatic disease uh, and if you had a recent spinal fracture and make sure it's healed. But I'm a big supporter of it. Patients love it. And if they get the right chiropractor, it's been very effective. That we consider that part of the non-operative arm. So I love it.
Thank you. Next question. Can you reverse a fusion that's about 20 years old?
Well, I'm glad you asked that question. It's usually not a good idea, but we do it. But just I'm going to tell you how we do it. You have to assume that the joints in the back of the neck are functional because if you go in the front of the neck and take down a fusion, it only works if the joints in the back are functional. So it's done extremely rarely, and we recommend it because the likelihood of you getting it right, like you use advanced imaging, navigation, you take down the fusion mass, you put a device that moves in it so you can have motion. But the biomechanics may be off because there's adaptive changes that occur. Once you fuse in the front, there's adaptive remodeling of the joints in the back, so they may not function as well. So you're really taking a long shot, so be careful.
Thank you. What are your thoughts on McKenzie physical therapy on C3, C4, spondylosis, or the theory in general for neck or back pain?
I'm a big fan of McKenzie and I'm a big fan of Williams exercises. So one is flexion based, one is extension based, and some are described as centralizing the disc pathology back into the canal. Um, what I've found is some works well with some patients, some works well with other patients. So it's really patient specific. So if a patient finds they get relief, I'll give you an example. If you have an isthmic spondylolisthesis of the back, those patients do well with Williams flexion exercises. They do not do well with McKenzie extension exercises. So it's really patient specific. So in the neck, I take it slow and I'd experiment. because it's a form of physical therapy. And then patient will say, listen, that bothers my neck. I can't do that. So then you try the other strategy.
Okay, thank you. Going through to the next. Okay, this is a little bit specific, but any recommendation for a 74-year-old Parkinson's patient who has terrible back pain, spent 45 years as a dentist, has arthritis, spondylosis, very active, but always in pain?
Okay, so I do a lot of that surgery in that setting. Three things about Parkinson's disease. It's a motion disease. So whatever you decide to do, number one, you have to really make sure you use belts and suspenders. So if you do any type of surgery, if you do the standard procedure, it will fail because there's constant motion in the setting of Parkinson's disease. Number two, they're out of alignment. So a lot of these patients have really bad back pain because they're stooped forward. The body does not like, we call that a flat back posture. It does not like it. So the body's constantly trying to upright their posture to have horizontal gaze. So you're fatiguing the cervical thoracic, thoracolumbar fascia, and you're miserable. So in that setting, if the patient is of the appropriate substrate, you can do a sagittal realignment procedure to make them stand straighter, but not too straight so they can't see the floor. Because if you take a Parkinson's patient and you turn them into a professional tourist, where you pull them back and they're not going to like life. So you have to balance it perfectly to get horizontal gaze. And that works effectively in that patient population. And they feel much better, but they still have pain. Because remember, anytime you operate on degenerative disease, anytime you do that, you can make them better, but they always have discomfort when it comes to the axial skeleton, so the neck and the back. So some of my happiest patients are patients I did spinal realignment surgery on. But if you sit down and talk to them, how do you feel? Oh, my pain's 4 out of 10 now. It used to be 10 out of 10. Now it's 4 out of 10. I'm much happier. Nothing goes away completely. That's never going to happen with an aging pathology.
Thank you. Is it true a fusion for one level will affect the other levels eventually?
You have a 2.8% chance every year of developing junctional changes of degeneration above a fusion, and it maxes out at 30% over 10 years. Now, keep that in mind. Let me just repeat that again. 2.8% chance of developing junctional degeneration as a result of a fusion. Now, if you didn't have a fusion, but you had collapse of the disc space just from aging, the chances of developing junctional disease are 2.8% because whenever you don't have motion, it transfers stresses. Now, the irony is we looked at the studies of disc arthroplasty and fusion, and that's why a lot of people will do a disc arthroplasty to prevent that, to allow motion. But the studies that are non-conflicted haven't really shown there's a big difference. The conflicted studies, i.e. written by people who have a financial interest, shows that patients do better with an arthroplasty in that setting. So it's kind of confusing. So that's the reality. The jury's out, but any type of stiffening procedure will transfer stresses and will lead to degenerative changes at a incidence of 2.8% per year.
Thank you. I had a cervical discectomy with fusion in December. Can it really take up to 1 year for the pain and weakness in my arms to go away? Do you have any recommendations?
Well, what usually happens, and everyone's different, usually the arm pain gets better pretty quickly. Your weakness, if the nerves were adequately decompressed, will take time to get better, 3 or 4 months. Neck pain, if you look statistically, gets better 50% of the time. But that's just the general average. So yes, so I say up to 2 years, people can see improvements.
Thank you. This person has continued constant tingling in their left thumb even after a cervical steroid injection in C6. What should be the next steps? And a chiropractor did not help.
Okay, so this is what I say. If it's just numbness, be careful. I would get an MRI scan. I would see exactly what the pathology is. If it was getting worse, I would definitely do surgery if you had pressure at C5-6, because remember, the C5-6 level causes C6 pathology, and C6 goes to the thumb. Now, if the pathology wasn't that bad and I operate on someone with numbness, remember, numbness only gets better 50% of the time. So if it's not bad, I always say to patients, you may not get better, so can you live with the numbness? If it's getting worse and they have objective pathology, I would do surgery on it. But remember, It may only get better 50% of the time. It shouldn't get worse though. So numbness is careful. People love surgery for arm pain. People love surgery for arm weakness. People love surgery for myelopathic symptoms. Neck pain and numbness, you don't know what's going to happen. So be careful.
Thank you. Are swallowing issues when eating related to arthritic or degenerative back issues?
Well, in general, we'll talk about the neck. So degenerative issues can be normal aging or it can be pathologic aging, and that's arthritis, pathologic aging. And when we say arthritis, we tend to use that term when people are symptomatic. So you could have the same amount of normal aging as someone else, but you may be miserable and they may not. Now, if you have that and you develop spurs in the front of the neck, that can cause swallowing problems. If you have significant spurs, and we often remove those spurs surgically, we get an ear, nose, and throat consultation to get to do a swallowing study, and then we remove the osteophytes. So swallowing, you should be assessed. I mean, there's many different things why people may have swallowing problems outside of spine problems. They may have Barrett's esophagitis. They may have other things related. They may have a stricture of their esophagus. But assume all that's normal. The neck can be a reason why people have swallowing problems.
And thank you. There were a couple questions about cervical traction devices and if they're safe.
Well, I use cervical traction. You got to be careful. You should be evaluated first to make sure you don't have any significant instability because you'd hate to put traction on something where there's instability. So if you keep it low, and most traction devices that you get are like 2.5 pounds, stuff like that, it's usually not a problem. So I'm not against it. But I would be evaluated first to make sure they don't find anything weird going on because God forbid you put traction on someone who has basal invagination or instability. It could be a problem. So usually not a problem, usually at low weights, and it makes people feel good.
Will you define the age range you use to define younger when considering whether or not to perform surgery when the patient is experiencing radiculopathy?
Okay, so I always say if you're a young kid and you're in high school, we do everything we can, high school or younger, to stay out of an operating room. Who needs that at that age? But we operate sometimes. I've operated on 12-year-olds. I've operated on 14-year-olds because they're absolutely miserable and they can't go to school and they have a big disc herniation. But we start seeing the frequency of surgery begin after the age of 20. The most prevalent age is 36 to 45. And then it's a bimodal. And then it really it gets worse at 68 to older. And I tell people the body can handle spine surgery really well up until the age of 84, 85. And for some reason, the reserve is not that good. So people can safely have surgery to 82, 83, 84. After that age, if there's any type of arrhythmia or any patients don't do well, I've been doing this since 1992 as an attending. So I tried to cut it off. If someone comes in who's in their mid 80s, I'm like, listen, let's try everything we can. And usually I can get the family to support it. I only operate in that situation if it's a dire, critical problem.
Thank you. What are the best meds for osteoporosis?
Well, I always recommend either getting a CT with Hounsfield units or getting a DEXA scan. I look at it, they have osteopenia or osteoporosis, and then we have an algorithm. It's a chart. I love the TSH hormonal medications that are either injectable or once a year. And we actually require that in deformity surgery because if I'm going to put screws in the back, I want to make sure your bone is strong. So you start off with the calcium, the vitamin D, you go to the biphosphonates, and then you move on to the TSH hormone medications and anything. And again, we as orthopedic spine surgeons don't manage that. We have people in our group, like physiatrists that manage that because you really have to keep an eye on it. So, but that's what I like. I like to have people, I tell everybody over the age of 50, male and female, why not get a DEXA scan? Find out what your Z score is and treat it appropriately.
Thank you. Can neck pain cause lightheadedness and ringing in your ears?
In neck pain, well, I've had patients with degenerative disease have tinnitus. I'm not sure it's directly related, but I've seen that correlation. So I have them immediately see ear, nose, and throat, and a medical doctor for it. We would never do any type of surgical procedure for that because there's really no obvious connection. So, but I've seen cervical gem disease act as a trigger to give people occipital headaches, posterior uh, frontal headaches, tinnitus in their ears. I've seen it be a trigger, but it may be a migraine complex. But you should never do anything surgically to manage that.
All right, I think we have time for maybe one or two more questions. Just going through them. Okay. Three neurosurgeons recommended surgery, and I recently saw an orthopedic surgeon who recommended surgery. I had physical therapy. How do you decide which surgeon when they all recommend a different approach?
Well, this is what I would do. Years ago, when I came out in the 80s and 90s, the neurosurgeons took the pressure off the neural elements and the orthopedic surgeons fused. But then the training systems changed. So now you really want to find someone who did a spine fellowship. So I would never go to an orthopedic surgeon and I would never go to a neurosurgeon to have spine surgery. I would only go to a surgeon who did a spine fellowship. It doesn't matter if they came out of the orthopedic world or the neurosurgical world, because a spine fellowship is how we train. I have four fellows that I train. We train them on all the contemporary techniques of surgery, all the innovations and stuff like that. And all we do is spine surgery. You don't want to have it go to a guy that does hip replacements and does spine, or you don't want to go to a guy that does brain surgery and does spine, because he's not going to be focused. Now, if they all recommend different procedures, I'm curious to see what your films look like, because in a general sense, that shouldn't happen. They should come to a consensus. Now, they may say, I want to use this type of bone graft or that type of bone graft, or maybe I want to do an arthroplasty. But I tell, go to someone who's seasoned and experienced and has a good reputation that's been around for a while, and you're usually safe in that setting.
All right, thank you. A couple questions about cervical spinal stenosis and causes and treatment options for that.
Cervical spinal. So yeah, so cervical spinal stenosis. And if you're symptomatic and you fail non-operative treatment, we would do a laminoplasty, which you saw before, or we would do a decompression and fusion, or we can go in the front and take pressure off in multiple levels in the front, because I think what the question is, stenosis means multiple levels, and that's something we do every week. That's not a very complicated procedure. And when I say not complicated, it's something that a well-trained spine surgeon should be very familiar with and do well with.
All right. I think that's all we have time for today. Thank you so much, Dr. Vaccaro, for your informative presentation, for answering the questions. We apologize if we did not get to your questions. We did record this, so I will be sending it out to everyone who was able to join today and everyone who registered, so they'll be able to view it as well. So thank you again, everyone, and thank you, Dr. Vaccaro.
It was an honor. Thank you very much.
Have a nice night.
You too.